Welcome. Today I shall discuss about anemia of chronic disease. Now come to the anemia classification. As I have discussed in the earlier slide, we have to depend on the reticulocyte production index for anemia classification. RPI less than 2, RPI more than 2 or 2. First, we will discuss the RPI less than 2. Normally, in anemia, the RPI should be 2 or more as per normal marrow response to the anemia. But when it is less than 2, we can say the marrow is non-hyperproliferative. It is non-hyperproliferative marrow response. Under this setting, it is the deficiency of the nutrient, that is iron deficiency, cobalamin deficiency, and folic acid deficiency. Number 2 is the erythropoietin insufficiency, as in chronic kidney disease, chronic inflammation, cancer, etc. Number 3, it is the marrow insufficiency, as is myelofibrosis, aplastic anemia, myelofibrosis, like this. What is the RBC pattern? In the iron deficiency, it is normocytic normochromic anemia, RBC, in the early iron deficiency, but in the advanced iron deficiency, it is microcytic hypochromic RBC. In cobalamin and folate deficiency, it is the macrocytic RBC. Now come to the erythropoietin insufficiency, it is the normocytic normochromic RBC. In marrow insufficiency, it is normocytic normochromic RBC. Now come to the RPI 2 or more. This is the hyperproliferative marrow response. Under this setting, two important items: chronic hemorrhage and hemolysis. What is the RBC pattern? Chronic hemorrhage, it is microcytic hypochromic RBC. It is like the picture of severe iron deficiency pattern. Under the hemolysis, there are so many items under hemolysis like hemoglobinopathy. Under the hemoglobinopathy, it is thalassemia, sickle cell anemia. Similarly, it is enzymopathy like G6PD deficiency, membranopathy like hereditary spherocytosis, electrocytosis, paroxysmal nocturnal hemoglobinuria, hemolytic uremic syndrome, microangiopathic hemolytic anemia, autoimmune hemolytic anemia, toxin, and so on. And what is the RBC pattern? Usually it is normocytic normochromic, but in case of thalassemia, it is hypochromic microcytic RBC. So, if we see a picture of hypochromic microcytic RBC, we have to think three things. Maybe case of severe iron deficiency, it may be case of chronic hemorrhage, it may be case of thalassemia. So we have to depend upon the ferritin, serum ferritin level for detection of the severe iron deficiency or chronic hemorrhage, and for thalassemia or confirmation is to be done by hemoglobin electrophoresis. Percentage distribution of anemia. Out of total anemia, maximum is iron deficiency anemia. It counts 50 to 60% out of total. Next is the anemia of chronic disease, including chronic kidney disease and other inflammatory condition, including cancer. It is 25 to 30% out of total. Next is the vitamin B12 and folic acid deficiency, 5 to 10%, hemolytic anemia, 1 to 3%, marrow failure anemia, 1 to 2%. Now we will discuss about the anemia of chronic inflammation, chronic disease, and CKD, that is chronic kidney disease. In this picture, we see the kidney which liberates erythropoietin, which is acting over the bone marrow for production of the red blood cell. So what happened? In chronic inflammation, recurrent infection or long-standing infection or cancer, there is liberation of the cytokines. These cytokines inhibit kidneys as well as bone marrow. So, less secretion of the erythropoietin from the kidney and less action of erythropoietin over the bone marrow. So, there will be less chance of production of the red blood cell from the marrow. On the other hand, this inflammation, infection, cancer causing cytokine release, these cytokines acts over the liver. Now we know that duodenum and jejunum are the primary site for iron absorption, and reticuloendothelial store is another store site for the iron, which liberate the iron for requirement of the bone marrow RBC production. But when the cytokines act on the liver liberates hepcidin. This hepcidin inhibit iron absorption from the duodenum and jejunum as well as from the reticuloendothelial store. So the net effect, decreased production and action of erythropoietin. Number 2, insufficient iron supply in marrow. So there is development of anemia, and this anemia is normocytic normochromic type. In the right side of the picture, once again see the erythropoietin liberation from the kidney going to marrow. But in chronic kidney disease, there is less secretion of erythropoietin from the kidney. So there is decreased production of erythropoietin. As a result, there is decreased marrow response and decreased RBC production, and normochromic normocytic type of anemia develops. This is the overall pathophysiology of anemia of chronic inflammation and chronic kidney disease. Let us discuss about the anemia of chronic disease or inflammation. If we compare the inflammatory anemia and iron deficiency anemia, the anemia in inflammation is usually mild, but this anemia in iron deficiency is mild to severe. RBC morphology in inflammation, it is normocytic, but in iron deficiency it is normocytic microcytic. Early stage it is normocytic, in advanced stage it is microcytic. Regarding MCV in inflammation, it is 80 to 90 hectoliter, it is normal. In iron deficiency, it is 60 to 90, it is normal to low. Serum ferritin in inflammation is 30 to 200, is almost normal, but it is in the iron deficiency, the serum ferritin is less than 15. It is the serum ferritin which differentiates between inflammatory anemia and iron deficiency anemia, particularly in the early stage of iron deficiency anemia when the RBC is normocytic normochromic. At the state, we can differentiate it from the inflammatory anemia when the RBC morphology in that case is normocytic normochromic. So between the two pictures of normocytic normochromic of inflammatory anemia and normocytic normochromic of early iron deficiency anemia, it is the serum ferritin which helps us, guide us for determination of the actual anemia cause. Now come to the TIBC, it is usually less or low in the inflammatory anemia, whereas in the iron deficiency anemia it is high. So it is the serum ferritin which differentiates between the true iron deficiency anemia and iron restricted anemia of inflammation. Treatment. Treatment of anemia of inflammation or chronic disease or CKD. First is the treatment of the underlying disease. Number 2, transfusion. If hemoglobin level is less than 7 to 8 gram per deciliter, causing cardiovascular compromise, needs RBC transfusion, red cell transfusion, it is blood transfusion. Our target hemoglobin is around 11 gram per deciliter. The third point is erythropoietin treatment. Useful when it is low erythropoietin, that is in the chronic kidney disease and inflammation. Usual dose 50 to 150 unit per kg, either subcutaneous route or IV route, 2 to 3 times a week. IRA status must be evaluated and IRA store must be replaced for optimal effect of erythropoietin. Thank you to all.